To construct an effective initial management plan, including deciding whether supportive measures are all that is required and determining if the cause of the ear pain requires additional investigations, referral, or both. This is very important. This is very important. Part of your management. Which of the cases of otitis media will you give antibiotics? Which of them will you withhold antibiotics and observe? That is what this objective is about. So when you are learning, these are the things you want to hit on. So if the decision is to prescribe antibiotics, prescribing only an antibiotic is not appropriate care. What do I mean by that? Don't forget that when the child comes in with otitis media, the child has pain as well. So it is not enough to say that I'm going to prescribe antibiotics. After you've prescribed antibiotics, you also have to manage the pain. And at times, because of the pain they are in, they may not even be eating, or they may not even be, hydrating very well. So you want to also make sure that they are hydrated well. So there are 3 things you want to do in a child with otitis media. Number 1, you want to make sure that the pain is managed. Number 2, don't prescribe only antibiotics. Prescribing only antibiotics is not appropriate care. And number 3, make sure that the child is hydrated. But the big question I'm asking today, according to the objective, and I want to go back to it, deciding whether supportive measures are all that is required. So there are some patients you have to decide whether you're going to give them only supportive measures. And there are some patients you need to start antibiotics right away. So if I were you, I'm going to create in my book, my notebook right now, which patients can I say that I'm going to give supportive management and watch? And which patient am I going to give antibiotics right away? So the question is this: should every child with acute otitis media receive antibiotics right away? No. Not every child you diagnose with acute otitis media should receive antibiotics right away. And this is a very, very critical exam step. Okay? Not every child with acute otitis media should receive antibiotics right away. So who qualifies not to receive antibiotics and rather go through what we call watchful waiting? Who qualifies for watchful waiting? Number 1, if that child is healthy and that child is more than 6 months of age, and that child has just unilateral, non-severe, suspected otitis media, you can observe that child. So we are now looking at the children who don't need antibiotics right away. Number 1, that child should be more than 6 months. The pain and the otitis media should be unilateral, non-severe, and you should only be suspecting it. Number 2, that child, remember that we said that otitis media, they should have middle ear effusion. You thinking this child may have otitis media, but then when you do your otoscopy, when you check, there is no effusion. There is no effusion. You can say, okay, I can let this child come back for reassessment. Usually the reassessment must be done within 48 hours. Or if the child gets worse, then the child comes earlier. Number 3, with middle ear effusion but non-bulging tympanic membrane. So you can see that you can have a child who is, say, 8 months, because the child is above 6 months. The child is having ear pain. You check the eardrum. There is middle ear effusion, but then the tympanic membrane is not bulging. Okay, that child, you can also do watchful waiting. And then there are some of them, you just look at the eardrum, and the eardrum is like, hey, I'm just mildly red. I'm not very red. I'm just mildly red. If you see that as well, you can do little watchful waiting and see. So the teaching point we are learning, and the medical council wants you to know, is that not every child who comes to you should be given antibiotics right away for otitis media. But then for them to be given antibiotics or not to be given antibiotics, they must fulfill this criteria. So now the other question is this: what are the steps in watchful waiting? Now that you want to do watchful waiting in that child, what are the steps? First, you have to make sure that this child qualifies. The child is more than 6 months. Number 2, the child does not have middle ear effusion. And even if the child has middle ear effusion, the tympanic membrane is not bulging. All right. And then the redness is just very mild. If that child qualifies, what goes into the watchful waiting? Number one, you want to hydrate the child and give the child analgesics, Tylenol, ibuprofen. Okay. Then you want to reassess that child within 48 hours or earlier than the 48 hours if the child is not improving. If the symptoms are worsening, then you want to start antibiotics right away. So let me say it again. What is the criteria? Can somebody tell me, please? Somebody should raise the hand, unmute themselves, and then tell me what is the criteria that a patient must fulfill in order for a doctor to say, I'm going to do watchful waiting of acute otitis media. Oh yeah, please tell me something quick. Let's go. Tell me something.
If the patient qualifies for watchful, hydrate and if they qualify. So the patient is healthy and above 6 months.
Beautiful. One. What else?
Without middle ear effusion and with non-bulging middle ear effusion.
Okay.
Mildly erythematous tympanic membrane.
Beautiful. When do you want to reassess that child?
Within 48 hours.
Beautiful. Or if the symptoms get worse. Again.
Get worse. Yeah.
Yes. Now, what's the first line? Amoxicillin. What's the next line? What other medications can we give? Cefprozil, cefuroxime, ceftriaxone, azithromycin, clarithromycin. In fact, if the second line does not work, you can then go on to amoxicillin plus clavulanic acid. Okay, first line is amoxicillin. Next line, cefprozil, cefuroxime, ceftriaxone, azithromycin, clarithromycin. If second line does not work, go to amoxicillin, clavulanic acid. Now, the third category of people that was saying these are people who need antibiotics no matter what. So I set a question on it. You see a patient in a clinic for an acute otitis media, you decide to start antibiotics right away. Which patient group will prompt such an action? Please type your answers. I want 3. Which patient group will you see that you go like, man, this patient needs antibiotics right away? Please type your answers. Let's go.
Patient with a high temperature, patient with discharge, highly inflamed tympanic membrane, maybe that need right away antibiotic.
Well, so those are interesting. Let's see. Who else has typed something different? High fever, bilateral, infectious baby, perforated member, immunocompromised, bilateral otitis media, absence of bony landmarks. What is the textbook answer? Remember that we said that children who are more than 6 months, they can be monitored if they are healthy. So that's if I were you, any child who is less than 6 months.
The symptoms more than 48 hours, not improving, worsening of symptoms.
Well, but then we are talking about the fact that the first day you see the patient, you go like, no, this patient needs antibiotics. Because if you say that the symptoms are not improving after 48 hours, that means it looks like you've seen the patient, you've told the patient to go home, do watchful waiting and come, right? But this is the textbook definition of those who need antibiotics right away. Please write it down. I saw that.
What about children who are ill looking? All children who are ill looking, like
so that's the number 2, right? So children who are less than 6 months of age. And in fact, if the child is less than 3 months of age and the child has fever, you want to even do a complete septic workup. So that one is another discussion on its own. I think I've even done a video in our YouTube channel, so you can go and check that out. Okay. So now, what children will you say? I see this child in the clinic or in the emergency room. I diagnose this child with acute otitis media. This child needs antibiotics right away. Number 1, age less than 6 months. Number 2, child is ill appearing. So if the child has shock, poorly responsive, the child is floppy, the child is drowsy. Number 3, if the clinician suspects another bacterial illness, which is not otitis media, so like urinary tract infection. Number 4, if the child has had recurrent acute otitis media, so the mother comes and says that, oh, my child was treated for an ear infection 2 weeks ago, 3 weeks ago, and then the child is tagging the ear again. Boom, you want to start antibiotics right away. If the child is immunosuppressed, immunocompromised child, and uncertain access to medical care, maybe the child is living in a situation where you are not sure whether or not the mother can bring the child back to the hospital, back to the emergency room, back to the clinic. You want to start antibiotics right away. And then if the child has maybe some craniofacial abnormalities, like cleft palate, cleft lip, all those things, you want to start the child on antibiotics right away. Doctors, does this make sense, please? Does it make sense? Does it make sense? Are we all tracking? Are we all tracking? Are we all tracking? Are we all tracking? Beautiful. So now let's summarize everything. Let's summarize everything. And that's why I like Tintinale so much, because it's a very good book. And I'm using materials from Tintinale, up to date, whichever textbook you can think about. So it's not just one book. But I like this schematic diagram from Tintinale, page 759. Okay, the 7th edition of Tintinale. Acute otitis media. What are the 3 things we have to fulfill? Number 1, acute onset of symptoms less than 48 hours. Number 2, middle ear effusion. Number 3, middle ear inflammation. If the child is less than 6 months, we learned it, start antibiotics right away. If the child is more than 6 months, the child is well looking, tympanic membrane is just mildly erythematous, there's no middle ear effusion, or even if there's middle ear effusion, there's no tympanic membrane bulging, then I can say that I'm going to do a little bit of watchful waiting. But if I have a child who is, say, more than 6 months, but the child is ill appearing, and the child has had documented otitis media within 1 week, and concurrent antibiotic treatment, and the child is still not getting better, and the child's mother cannot bring the child back to be assessed, or there are other bacterial infections I should be worried about, or the child is immunosuppressed, or the child has craniofacial abnormalities, this child, I'm going to start antibiotics right away. But if the child does not have any of those high risk factors, then I'm going to do watchful waiting and see. And I'm going to just prescribe some Tylenol, some Advil, encourage them to hydrate, okay? And if the symptoms worsen within 48 hours, then I'm going to get a child in and start on antibiotics and analgesics right away. But if that is not the case, then we'll just follow up, because otitis media can resolve on its own. So please, this is a schematic diagram which explains everything we've discussed up to this point. So now you should be able to know, as the objective said, which people do you want to start on antibiotics, which people do you want to do watchful waiting. You should be able to kill that easily. All right? Good. Now, what are the complications of acute otitis media? What are the complications of acute otitis media? Number 1, hearing loss and speech delay. Number 2, tympanic membrane perforation. Number 3, there can be mastoiditis. Number 4, there can be labyrinthitis. There can be cholesteatoma. There can be facial nerve palsy. It can even extend into the brain and cause meningitis. It can lead to epidural or brain abscess. Subdural empyema as well can occur, and then there can be lateral cavernous sinus thrombosis and facial nerve paralysis, and there can be post-auricular abscess. So please, just learn some of the complications. Pick about 4, master them. 4 or 5, master them. 4 or 5, please master about 4 or 5 of the complications of acute otitis media, and you should be good.